This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Clinical Neuroscience, the official journal of the Neurosurgical Society of Australasia, published in 2026. The paper is titled Clinical Outcomes of Microvascular Clipping Compared to Endovascular Coiling for Ruptured Anterior Communicating Artery Aneurysms.
This is a topic that hits home for anyone who takes vascular call. Ruptured intracranial aneurysms are, as the authors state, a devastating pathology. We aren't just talking about a technical challenge. We're talking about a condition associated with significant morbidity and mortality.
Exactly. And when we look at the distribution of these lesions, the anterior communicating artery, or ACOM, stands out. In fact, the paper highlights that the ACOM is the most common location to have an intracranial aneurysm form and rupture.
It's the bread and butter of vascular neurosurgery, yet it's also one of the most anatomically complex areas because of the proximity to the optic chiasm, the hypothalamic perforators, and the dual inflow from both A1 segments. For decades, we've been debating the best approach. Alara, the study points out that there are two primary management options: microsurgical clipping and endovascular coiling. What was the specific impetus for this review?
The authors noted that while we have plenty of data on aneurysms in general, think back to the ISAT and BRAT trials, the clinical outcomes of microsurgical clipping specifically compared to endovascular coiling for ruptured ACOM aneurysms remain unclear. There is a lot of heterogeneity in how these patients are managed globally.
That's a critical point. ACOM aneurysms have unique features: projection, neck-to-dome ratio, and relationship to the recurrent artery of Hübner that might make them more suited for one modality over the other. The aim of this review was quite comprehensive, wasn't it?
It was. The investigators wanted to investigate the clinical outcomes across three main pillars: functional outcomes, treatment efficacy, and safety. They really wanted to see if the data supports one modality over the other when we specifically isolate the ACOM location in the setting of subarachnoid hemorrhage.
Let's dive into those pillars. When we talk about functional outcomes, we're usually looking at the modified ranking scale, or the Glasgow outcome scale. In the context of a ruptured ACOM aneurysm, we aren't just worried about motor deficits. We're worried about the cognitive and behavioral changes that often follow ACOM ruptures due to frontal lobe involvement or perforator territory strokes.
Right, and that's why safety is such a big part of this study. For clipping, safety often revolves around the surgical approach, the craniotomy, the brain retraction, and the potential for direct vessel injury. For coiling, the safety profile usually focuses on the risk of intraoperative rupture or thromboembolic events. The review seeks to clarify which of these risks carries more weight in the ACOM territory.
And then there is treatment efficacy. For a neurosurgeon, efficacy isn't just about surviving the procedure. It's about the durability of the exclusion. We know that coiling historically has a higher rate of recurrence or need for retreatment compared to the definitive nature of a well-placed clip. However, in the acute phase of a rupture, the priority is preventing a rebleed while minimizing the physiological stress on a patient who has just suffered a major neurological insult.
That's the core of the dilemma the paper addresses. Because the clinical outcomes remain unclear, the review serves as a necessary deep dive into the recent data to see if modern endovascular techniques, like balloon-assisted or stent-assisted coiling, have closed the gap, or if the gold standard of microsurgical clipping still holds the advantage for this common location.
For our residents and students listening, it's important to remember that the ACOM complex is a high-stakes environment. Whether you are using a microscope or a fluoroscope, the goal remains the same: complete obliteration of the sac while preserving all the parent and branching vessels. This study helps us move closer to an evidence-based consensus for a patient population that is often at high risk for poor results.
It really highlights that while we've made incredible strides in both microsurgery and endovascular technology, we still need this kind of focused, location-specific research to guide our clinical decision-making.
Well said. This paper is a great reminder that even in common pathologies, there is always room for more clarity. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
We'll see you in the next episode.